So in menopause, labs can confirm menopause. So like if I'm someone, say I've had a hysterectomy or an ablation or I have an IUD that I don't want to take out, but I do want to know if I'm in menopause. Labs can confirm menopause. And every situation is different, but that's one reason to look at labs. But in perimenopause, that's a whole different thing. Estrogen's going up and down. I can have, let's just say hypothetically, I have my labs drawn at 8 a.m. and my estrogen is 150. At noon, if I were to have labs again, which we don't do, but if I did, my estrogen might have gone from 150 to 50, and both of those levels are normal. Anywhere from 10 to something like 600 estrogen in perimenopause is normal. But I don't feel the same as I feel if I go from 150 to 50. When I'm dropped that much, I don't feel normal. So labs don't tell us much.
You are listening to Perimenopause Explained. This show is about perimenopause, the years before menopause, when things start changing, also before anyone calls it menopause.
Each episode is real talk from real questions to explain what's going on in your body. No hype, no minimizing, just straight answers and honest conversation.
If something feels off and you haven't gotten clear explanations yet,
this podcast is for you. Welcome back to your show.
Hi, Steven.
I'm Stephen Youngblood, medical director, internist, and co-founder of the Menopause Clinic. And this is Crystal. Crystal, introduce yourself.
Hi, I'm Crystal Burke. I am a nurse practitioner and menopause specialist and co-founder of the Menopause Clinic.
And this is Perimenopause Explained. Right. So, quick reminder, this podcast is about science, symptoms, and solutions for perimenopause and menopause. We are not diagnosing or treating. And Crystal, I thought we'd start today with an article I came across. It was at the Journal of Clinical Endocrinology and Metabolism. You know, you see those magazines hanging out everywhere now.
So real fancy scientific
stuff, right?
Yeah.
And this was a very scientific article with lots of statistics. So, you know, only the science geeks in us would have gone through the article. But I did want to talk about it a little bit.
You're going to explain it.
So we're going to explain it a little bit and just kind of keep it at simple levels. But I thought it was an interesting series of talking points. The article showed that women with insulin resistance had worse vasomotor symptoms during perimenopause and menopause. So worse hot flashes and all the night sweats and the other symptoms that come along with it. And it kind of suggested that higher insulin levels was a instigator of these worsening symptoms.
Okay.
Now it also correlated well with body mass index. So when we know higher body mass index generally will lead to more insulin resistance. Mm-hmm. So, and more insulin resistance generally leads to higher resting or fasting blood glucose sugars.
Yes.
Okay. So give me your take on it.
So tell me what this means to any woman. Like, what does this mean in English?
In English, yes.
Yes.
So in English, it would suggest that if you're prediabetes, overweight, you're at higher risk for having worse perimenopausal and menopausal symptoms, specifically the vasomotor, which will be the hot flashes.
So that makes sense. Okay, so that makes sense. So the thing is, though, is that even just going into perimenopause puts you more at risk for insulin resistance and higher BMI. So this is all a big circle that's a mess that is perimenopause, is what it means to me.
So are there any other endocrine disorders that could worsen the symptoms of perimenopause?
Well, I mean, basically perimenopause, there's a circle. Other conditions haven't been known. Like there's not anything that says if you have this condition, perimenopause will be worse. However, perimenopause can worsen any condition you have. So it is kind of like a circle. But yeah, I mean, I can see how, because I think what did the study look at? Do you remember the specifics of the study?
A little bit of the specifics, yes.
Yeah, what were they looking at specifically?
So I think they were mostly looking at body BMI.
Yeah.
And they did some serum insulin levels, which is something clinically we would never do.
Yeah.
And they were also looking at serum glucose levels.
Yeah. So, I mean, basically, the thing is that perimenopause can affect other things, and other things can affect perimenopause. Is what I'm taking from that, right? So yeah. I mean, we know. I feel like we know that, but it's good that they have these studies that are saying that, so that it's clear.
Yeah.
But yeah, it's really interesting.
It is absolutely
Really
is.
interesting.
So in theory, if a person a woman was able to exercise and diet, which we know is incredibly hard for weight loss, but if they were able to lose some weight, in theory, it could potentially lessen their symptoms. But in the setting of perimenopause and menopause, that's really hard to do.
Yes. So basically, I guess what I'm taking from that is if you're at a good or a BMI that is within a certain range, what it's saying is that your likelihood of perimenopause symptoms being less is likely. But the thing is going into perimenopause, you can have a normal BMI, but your BMI can go up despite exercise and despite diet.
Diet, right.
So, I mean, that's the thing, is it's just a big circle.
Absolutely. So I looked up some of the risk factors for higher, insulin resistance. And one of the ones that came up was chronic stress with poor sleep, which pretty much describes standard American condition, right?
Right. Especially perimenopause, though.
Right. Absolutely. Is poor sleep habits, whether it's something you see often in perimenopause?
That is one of the most common things, but that's the thing, is it's not always poor sleep habits. It's poor sleep.
Poor sleep.
But not always, because again, you can do everything right. You can go to bed on time, and you can even sometimes fall asleep fine, but you wake up in the middle of the night because of biology and because of what's happening to your hormones, not because of anything you're doing. Like what happened with me, I could not sleep. I was doing everything mostly right, but I was trying.
Minus the 6 Cokes a day.
Well, yeah, but I've done that my whole life.
True.
But that's the thing, is you can have bad habits your whole life, but all of a sudden they're affecting you in a different way. There's something else different going on there. So yeah, sleep is a very common problem. It's one of the most common problems. So yeah. But we do see insulin resistance and cholesterol go up in perimenopause. But that's the thing, it's an inverse relationship. So estrogen goes down, insulin resistance, and cholesterol go up.
Well, cholesterol is something, easier to measure than insulin resistance. So have you seen patients where their cholesterol was out of whack, quote unquote? Because it's really not we don't look just at total cholesterol, right? We're looking at ratios of the bad to the good and all that. So have you seen a situation where someone got on HRT therapy and all of a sudden their cholesterol levels right-sized and came back to a good level?
Yes. One of those things.
That's why I asked the question.
Yes, one of those things.
So tell me about that. Give me some your experiences on that and just how it made you feel.
Yeah. So I had always had low cholesterol.
Better than mine. Much better than mine.
Which is weird, because mine must be hereditary. I must have good cholesterol hereditarily, because my eating habits were never and definitely my exercise habits not as good as yours. But I always had really good cholesterol until I was about 38. And then it went straight up. With the graph, it went straight up. And then it kept going up, although nothing else changed. I was gaining weight, which was probably also insulin resistance that we don't check for.
Right.
But you know what? My A1C was going up too.
Mm-hmm. How high? Do you remember how high it got?
5.6. It's always been around 5, but I was almost
5.6 is borderline for prediabetes, right?
Yeah. I was almost pre-diabetic, but although nothing had changed in what I was doing, and then it went right back down.
Absolutely.
Both of them. Now it's like my A1C is like 4.8. It's
super therapeutic.
Yeah.
All righty. So from this point, we're going to move on into some questions that we've commonly hear, commonly pick up on social media.
Yes. Real questions.
Real questions that people ask us all the time.
Yes.
Sometimes the questions are asked in the middle of the street.
Which happened recently.
At a Mardi Gras parade.
Uh-huh.
Yeah. So first question, why doesn't my OB-GYN bring up perimenopause or HRT?
Yeah. That's a great question.
And then was that the one that she asked us in the middle of the street?
Uh-huh.
Okay, yeah.
Yeah, that was. Well, because just like me, just like you, your OBGYN, PCP, we're not trained in menopause. Perimenopause is a whole different physiological condition that was never mentioned in nurse practitioner school for me and never mentioned in medical school for you, right?
Right.
So OBGYNs, the studies show that 30% of them, only 30% of them, even had menopause training for 3 hours. So the rest of them had no menopause training. And that, even those 3 hours were on menopause, not perimenopause, which is a whole different physiological condition. In menopause, estrogen is declining steadily, and the symptoms are different because it's just a different part of the process. But physiologically in perimenopause, it's up and down, up and down. It's treated differently. It is a different process. So your OBGYN and PCP haven't been taught that. And so that's hard for them to bring up because it would be like your dermatologist talking to you about cardiology.
Right.
It's not a fair expectation, especially when you consider all the things that go into perimenopause. So one of the worst things for me was brain fog. So your OBGYN isn't trained on brain fog and attention and focus and sleep. So that's why women get sent to multiple different specialists. But that's your OBGYN is trained mostly on fertility, like birth control, fertility issues, and that like menstrual irregularities, hysterectomies. There's surgery involved in that. Perimenopause isn't taught to them. The people that I know, like I got additional, like I looked for and went for special training. It just wasn't taught in school. So that's why an OBGYN and a PCP, it's going to be difficult for them to do because they weren't taught it and they're doing other things.
Right.
So
how long did that additional training take you?
So it took me a while to find someone.
Okay.
It took me a while to find someone. The training, it was because I have the other training, it was about 6 months for the training for that. But I also attend meetings every month so that I keep up on everything. Because the thing is like a lot of people will think, oh, well, it's just prescribing a patch. No, there's a lot involved in this. There's the patch has to match the progesterone. But what if someone has progesterone intolerance? What if this doesn't work for them? There's a lot involved. So there's ongoing education. So that's the thing. And that's going to be hard for someone who that's not their primary focus.
Mm-hmm. And yeah. And like, I guess from the standpoint of an OB-GYN or any physician, nurse practitioner, seeing a patient that with a medicine that requires multiple titration steps over weeks, months?
So weeks to months, yeah.
Weeks to months, right.
Yeah. And then in perimenopause, it can take you weeks to months to get really good at where you are, and then 6 months later be at a completely
different spot.
Because your body's changing.
Mm. And even in the field of like cardiology with their heart failure clinics, a lot of these medications have to be titrated fairly frequently. And so they've developed entire clinics where that is just their one job.
Right.
Is to go out and make sure that, are you weighing yourself? Okay.
Yeah.
Medicine, click up one level see you back in a week or two, click up another level.
Yeah.
And again, even in that field, it's, 3, 4, 5 medicines that they're trying to adjust to find the right thing.
Yeah. Yeah.
So, all right. Second question that we often hear is around blood work.
Okay.
And the question usually goes something like this. I feel awful, but I'm told my labs are fine.
Mm-hmm. Yeah.
So give me some information around that. Like how do you use labs in the process of perimenopause versus menopause versus all the other times?
Yeah. So I'm glad you said that, because that is different. So in menopause, labs can confirm menopause. So like if I'm someone, say I've had a hysterectomy or an ablation or I have an IUD that I don't want to take out, but I do want to know if I'm in menopause. Labs can confirm menopause. Especially for, and every situation is different, but that's one reason to look at labs. But in perimenopause, that's a whole different thing. Estrogen's going up and down. I can have, let's just say hypothetically, I have my labs drawn at 8 a.m. and my estrogen is 150. At noon, if I were to have labs again, which we don't do, but if I did, my estrogen might have gone from 150 to 50. And both of those levels are normal. Anywhere from 10 to something like 600 estrogen in perimenopause is normal. But I don't feel the same as I feel if I go from 150 to 50. When I'm dropped that much, I don't feel normal. So labs don't tell us much.
Okay. So when would you use lab work anywhere in your treatment protocol? Like, because I've heard of a saliva test and a few other tests where I can't think of an example when I would ever test anyone's saliva, but
yeah. So there's so many different types of perimenopause care, right? So there's functional, there's integrative, there's evidence-based, there's different kinds. So we do evidence-based. So we go by the Menopause Society guidelines, American College of Gynecology guidelines. We go by very specific guidelines that say that the best way to test for estrogen is by blood. So we don't use saliva tests. So what would we look at blood work for? So say I talk to somebody who is having perimenopausal symptoms, understands that lab isn't going to tell her whether her symptoms are related to perimenopause, but she wants to know her baseline. Like I want, maybe I just want to know what my estrogen is now. If I want to know that, then yeah, I think having labs are worth it for you. If you have information you want to know about your body, yeah. But is it going to help guide treatment? Not necessarily, because your symptoms matter more than the number on the paper. And it can be very discouraging to know that something's wrong. Like, I know I can't sleep, I have brain fog, I have low libido, like I have all these symptoms, something's wrong, but I look at a piece of paper and the number's normal. That's very discouraging. And that's not the whole picture. So that's why labs can be harmful in some situations. But if a woman wants to know what her baseline is, then yes, she should have it. Also, a lot of times, not a lot of times, but sometimes symptoms can look like thyroid. It could look like other problems like thyroid or other conditions. So if we can test before to kind of see, is it related to the thyroid? Could it be both? Could there be overlap? So sometimes that could be very helpful.
Okay. So the next question evolves around age. And this is something that I think in our first episode, we had a long conversation about when we were talking about you. And so often hear someone mid-30s say, well, I'm too young. And then you can ask them something like, well, how are you sleeping? Oh, I sleep terrible. When did it start?
Right.
Like 6 months ago.
Right.
Right. So what is too young for perimenopause? And, when should, on average, women should expect something to start happening?
So this is the hard part, because if there was a certain, like if we were talking about menopause, then yeah, we'd be looking at 51 is the average age. So between 45 and 55. Perimenopause is 10 years before that. So on average, it can be between 35 and 45, most commonly in the early 40s, but studies show it can happen as early as 34. So there's a lot of answers in there, but basically 34 and up. Although, does that mean that someone can't go into perimenopause or menopause much earlier than that? They can. Yeah.
Okay. And what's the ballpark, the latest a woman should expect for, I guess, really probably more like menopause. So again, remembering menopause is 12 months without a period. So we're talking about menopause is the ovaries aren't doing nothing.
Right.
Right. So what would be the latest? Would it be 70?
I mean, could that have ever happened? Maybe, but it's not likely. So average menopause is 45 to 55. Could you be, after 60? Yeah, but typically it's going to be in that range or just after it, if that's the case. But yeah.
Yeah, that'd be crazy. 70-year-old woman getting pregnant.
Yeah, that will be something.
All right. This is a topic that I think we've heard a lot of women mention. And so here the question is, why do I, as a woman, feel dismissed when I bring up hormones?
Well, because most of the time you are. Sadly, you are. Because most of the time, I mean, again, we weren't taught this. I wasn't taught it. You weren't taught it. And so when you're talking to a provider, a physician, a nurse practitioner, a PA, most of the time they weren't taught this, so they don't know. So without knowing, then there's not really an answer that you're going to get, which then you feel, understandably so, you feel dismissed. Because there's not an answer.
Right.
I mean, we've talked about this before. Like for you've seen women that had complaints, joint pain and insomnia, and you didn't know how to help them, right?
Right. So, yeah, I mean, when a person comes in with a complaint, it doesn't really matter the complaint. They have a complaint. You do what you do. You do an exam, you ask questions. Probably going to do some blood work at some point or an x-ray, depending what the complaint is. And at the end of the day, if nothing comes back, I can't fix this. This is an unfixable thing for me. And I think that's where it gets complicated when you have a diagnosis that is purely a clinical diagnosis, right? There's no one lab you can hang your hat on. There's no x-ray test, ultrasound, EKG, EEG. We can test a lot of cool things, but there's a lot of things that are still, at the end of the day, a clinical diagnosis. You just have to ask the right questions, and that whatever it is has to pop into your head. And I think for a long time, when we don't know what it is, the follow-up question is, do you feel depressed? Do you feel anxious?
Yeah. What's going on in your life?
What's going on in your life?
That is making this in your head.
Right. And
stress. It's stress, anxiety. You have kids, you have parents, you have stress in your life, manage the stress better.
And, not to belittle anxiety, depression, those problems, they're very real. And for some people, they're just, debilitating. Mm-hmm. But I think we do have a tendency to go to those when we don't know what else to do.
Right. So that rightly so can feel like you're being dismissed, but there's a very clear and known lack of training around all of this. And even then, like when I'm talking to people, I can't tell you all the time for sure, is this perimenopause? I can tell you that you're in the right age range, as long as we know that you don't have other things that this could be. Sometimes it is a therapeutic and diagnostic trial to do HRT if someone wants it. Because if someone wants HRT, like they say, and I've had women that say, you know what, I don't care. Let's try anything, whatever. Okay, so we could try it. And if say we adjust and it hasn't worked and it hasn't done anything with adjustments, sometimes you need adjustments even within that period, right? So if it's been 3 months and we've adjusted and we've done the things that we can do with that, and it's not helping you, then no, it's definitely time to check everything else, even if you've already had things checked before. Because if that doesn't help you, then it likely isn't hormonal. But very typically in that age range, that is not the case.
Right.
That is not the case.
So you bring up an interesting point of the therapeutic trial, right? So we give you some medicines and we see how you do, which can be very complex because you're the patient that has to realize whether they're getting better or not. What are some tools you're using to help patients realize that they're getting better? Because and I saw this a lot when treating depression or fibromyalgia, where I do an intervention, and then I always tell them, look, you're going to have to do some journaling. You're going to have to go and write down what you're feeling at some point on some papers. And that way we know if you're getting better or not. Because if 3 months or, 4 weeks in, I say, how you feeling? He goes, I feel no better. Well, maybe you do, maybe you don't. And we have some tests that some tests. We ask questions. It's a scoring mechanism, right? To see how they're doing. So can you talk into that a little bit? Because I think it's an interesting point.
Yeah. So, I mean, it happens differently for every woman. But like if you take one of our good friends that started on HRT, at first she was like, yeah, I don't think it's helping me. And in one conversation, she's like, I don't think it's helping me. Well, wait, you know what? I didn't take a nap. I haven't taken a nap in 2 weeks. Maybe it is helping me. Wait, maybe I do feel better. So that's the thing is sometimes, our mind thinks, no, nothing has changed. But then as we really think about it. So one of the things, and life is life. And so it's not always easy, but I'm trying to develop this app to make it a little easier on people, but to track your symptoms, whether you track them twice a week, once a month, whatever time you have to compare, just track them. It takes less than 2 minutes. So we can kind of see, did this work for you? And so you don't have to, when I say, how are you feeling? It's not like I'm putting pressure on you. Tell me right now.
Right.
A yes or no, I'm determining the way that we're going to proceed from here. No, like I'll look back and go from there and we'll talk about it. It's not like, because sometimes when it's me and somebody says, how do you feel? Did that help? I don't know. No, maybe.
Yeah.
It's hard.
And how you feeling is, and providers, we're all really guilty of this. How are you feeling is such a vague, open-ended question. And then we get to ask, okay, let's get down to your sleep. Yeah. Let's get down to hot flashes. How many did you have this day? Like, is it going up, going down? All the other things. Yeah. It can become a little more, it can clue you into like, oh, yeah, I am getting better. Yeah. Right. Absolutely. Well, we're reaching end of time of this second episode. We've talked about a lot. We talked about insulin resistance and hot flashes. We've talked about labs, why it's hard to get treatment from just OB-GYNs and general physicians and whatnot. We discussed being dismissed. Do you have any take-home points, anything you just really like to, some key fact you would like our people to remember?
So yes. So if you're 34 and above and you feel different, one of the most common things is I don't recognize myself. But if you feel different at all, then it's worth it to consider perimenopause. That's one. Number two is, even if your labs are normal and you feel like something's off, it's probably off.
I think those are two good points. Two good points. Absolutely. All right. That's the end of this episode, Crystal.
Thank you for listening.
And if you have any questions, please send them in below or email us at our
menopauselouisiana.com. Our email address is on there. Send us your questions.
Absolutely. Thank you so much.
Thank you.
This podcast is for education only and doesn't replace individualized medical care. Our goal is to give you clear information, not to rush you, scare you, or brush things off.
We'll keep answering real questions and talking honestly about what perimenopause really looks like, feels like, and what you can do about it. Thanks for listening.